Hi, I'm Dr. Mike Milligan. We're here at the American Academy for Oral Systemic Health meeting in Dallas, Texas. And I have one of the top speakers here with me, Dr. Bertrand de Silva, board certified in pulmonary, critical care, sleep medicine, and internal medicine. Quadruple board certified. Dr. de Silva, thank you so much for being with us. Now, Dr. de Silva spoke to us about the problems with sleep apnea and the need for treatment. Dr. de Silva, could you tell our patients the problems created by sleep apnea?
Sleep apnea is the condition which results in obstruction of the airway repetitively at night. It causes low oxygen levels and it causes high carbon dioxide levels. The body reacts to that by waking up repetitively overnight. It causes symptoms of excessive daytime sleepiness, as well as fatigue, depression, anxiety, possibly sometimes multiple restroom visits at night. And the long-term complications are manifold. They cause problems with the heart, with heart attacks and cardiac arrhythmias, perhaps atrial fibrillation, as well as problems with diabetes, metabolic syndrome, multiple restroom visits, etc.
Yeah. And these cardiac problems and other problems, it's not just a little problem, it's a big one.
Well, people...
Big percentage.
The interaction of sleep and sleep apnea with cardiac arrhythmias result in these irregular heart rhythms, and what we find is that if we treat the sleep apnea, then we can treat the cardiac problems a lot better. For example, with atrial fibrillation, treatment of the sleep apnea reduces the incidence of atrial fibrillation to half of what it would be if the sleep apnea was not treated.
How young is it important to diagnose and treat and get these people treated?
I think prevention is much better than being reactive treatment. And one of the issues that we're having is that the suspicion for sleep apnea is very, very low. Patients are not really adequately being assessed by their primary care doctor, and they disregard sleep perhaps as a diagnostic possibility, primarily because they feel that the treatment is inappropriate in terms of positive airways pressure, CPAP treatment. So they don't want to diagnose a condition where the patient may not be fully adopting the treatment. So their diagnostic threshold is very, very high. Unless the patient is practically dying from the condition, they won't try to correct it. As a result of that, we are seeing very few patients that are diagnosed very early. They tend to be diagnosed very late in their condition, and perhaps in the intensive care unit situation only. It would be better if they were diagnosed a lot earlier, a lot more preemptively. A preemptive strike is much better than trying to react to a condition that has already occurred.
And at what level should someone be concerned? Even a level of 5?
Yes. What we have found is that research has demonstrated that an apnea-hypopnea index, which is the number of events per hour that the patient stops breathing, even a level of 5 increases their death rate significantly. So a level of 5 is something that should be assessed and treated aggressively. Different modalities of treatment, dental devices are definitely indicated for low levels of sleep apnea. And it's not just the big men anymore. We've realized that sleep apnea is pervasive throughout society. It affects not only the male population, but the female population, both the young and the very young as well. So it's not just the older men that need to be considered as a possibility for sleep apnea. Everybody needs to be assessed.
And what you briefly mentioned some of the modalities for treatment. Would you expand on that just a bit?
The treatment that is advocated in medicine is positive airways pressure treatment. It's a CPAP mask. It's uncomfortable. It's not something that people adapt to very easily, and it takes a lot of training. We have different modalities of positive airways pressure treatment available, lots of different masks available, but invariably it is a modality that takes a lot of training. It's not an on-off light switch. It takes several months to become accustomed to the CPAP machine. Different modalities of treatment, dental devices, even surgery, even correction of posture, myofascial therapy, etc. should be utilized in the treatment. And I think that what we need to do is to cast a much broader net in terms of diagnostic possibilities, and we should be trying to evaluate patients a lot more.
The importance of the physician working with the dentist, with a multidisciplinary team. Could you just briefly touch on that?
Yes, one of the problems is that we tend to work in a vacuum. Sleep physicians are isolated from dentists, dentists are isolated from the referring physician, etc., etc. I think that we should come together more as a team approach. We should have the ENT, the allergist, the sleep physician, the dentist, the orthodontist, the speech therapist, etc., perhaps housed in the same locality or perhaps even in the same building, and have a much more multidisciplinary approach to the treatment of sleep medicine.
What can the patient be looking for? What are the top few things that the patient themselves might look for that might tip them off or a dentist might look for, that might tip them off that, hey, we should screen you for sleep apnea?
Well, one of the things that occurs is that you could actually be witness to have one of these events. And I was asked that question earlier today as to what's the top question. And realistically, it's the spouse complaining that the patient has stopped breathing. The elbow effect at night has been also described, where somebody's actually seen that patient stop breathing. That is a certain giveaway that that patient has sleep apnea. Also, multiple restroom visits, waking up with a dry mouth, a headache, being sleepy at work, drinking lots of coffee, trying to combat the effects of sleepiness, etc. Those are the symptoms that one would look for. If they become more serious, then obviously heart attacks, strokes, irregular heart rhythms, etc. That's what's really precipitated by sleep apnea.
You mentioned dry mouth, so that would be someone who's breathing through their mouth as opposed to their nose.
Yes. Dry mouth breathing is very, very common in patients with sleep apnea, and what we realize now is that nasal breathing humidifies the air, and mouth breathing is an indicator of probable sleep apnea as well.
What else should we know, Dr. De Silva, before we close?
Sleep apnea is a condition, obviously, that is easily diagnosed. The modalities of treatment have improved dramatically over the course of the last few decades, especially in the last 3 years. The usage of auto CPAPs, the convenience of the dental device, etc., has improved significantly. And I would advocate that these patients need to be evaluated and treated much more aggressively in the future.
Dr. De Silva, thank you
so
so much for being with us.
Thank you.